Now, every year, ARC gets to report to the Congress on how the nation is doing overall in terms of quality of care and disparities in care. So the really good news is, A, we've got some metrics. This is not just about did someone follow a protocol, but how are we doing? We actually have an annual report and track a certain set of core measures over time. We've also seen every year since we started doing this in 2003, statistically significant improvements in care across all settings and populations. We've also noted that the magnitude of that change, although directionally great, improving every year, is relatively modest. So for this current report, we're saying it's about 2.5%. At a very high level, the good news is then we can say that there has been steady, although some would say glacial, but steady progress. No surprise, since the Affordable Care Act, the big provisions don't kick in until 2014, access to health care is not improving for most racial and ethnic groups. And in general, we tend to have been doing a better job with quality of care in terms of acute care services. What we're finding in this report is that for the metrics we have for acute care services, obviously this is rolling up many different conditions. People receive recommended care about 80% of the time. For chronic disease management, that's about 70% of the time. I will say that we're not using any composites in those metrics for chronic disease management. And for preventive care, that number is about 60% of the time. Now, all of those are better than Beth McGlynn's numbers from 2003 of 54.9%, but I think also underscore the magnitude of the improvement that's needed. And we see that progress is actually uneven. There is a very large collaboration or network called the National Priority Partners for Quality that actually has articulated 7 priority areas that are not disease conditions or even population specific. And if we cut the data that we have by that, what we find is that not only is healthcare access suboptimal, particularly for minority and low-income groups, but so is quality. And where quality overall is improving, access and disparities, frankly, are not. That's not to say that disparities are immutable. The great aspect of actually tracking the same metrics over time is we can actually see where there's been some traction. We just don't see very much of it. And we believe that, based on these results, urgent attention is needed to ensure continued improvement in quality and progress on reducing disparities. And the 3 areas we've really been highlighting this year are diabetes care and adverse events, disparities in cancer screening and access to care, and states in the South. So this graph here, where black means better, turquoise or blue means staying the same, and that funky green color means things are getting worse, shows that, or illustrates that adults over 65 received worse care than adults between the ages of 18 and 44 for 39% of the measures. Blacks received worse care than whites for 41% of the measures, and poor people receive worse care than high-income people for just under half of quality measures. And as I mentioned a moment ago, while we're seeing improvements in the acute care side, overall improvement remains uneven. The Secretary of Health and Human Services, Secretary Sebelius, asked me not too long ago, so how are we doing in quality? And I gave her in fewer words what I just said to you, and she said, and I was explaining that in the U.S. right now, the vast majority of hospitals, well over 90%, can actually, for those people with acute cardiac ischemia, actually achieve the door-to-balloon time less than 90 minutes. fairly complicated choreography of multiple people on a team whose actions need to be coordinated in a fairly short period of time. And without missing a beat, she said, now, is this a metric for appropriateness? Did all those people need the procedure? And I said, oh, that's not what we're measuring. We're assuming that every single procedure was absolutely necessary. This actually tracks execution. But if you look at other areas where people measure and report on quality regularly, I often think of NCQA, the National Committee on Quality Assurance's report cards on plans. What we see is that for chronic illness care, we're not doing so great. In the latest data that I've seen from NCQA, the top 10% of health plans, which includes some that I think we'd all be proud to be associated with, the top 10%, if you use any composite metrics, barely can get it right 70% of the time. This is not really, really sophisticated measurements, okay? This is a very conservative cut, for example, on hemoglobin A1C level, managing cardiac risk factors, and the like. So the problem there is clearly not evidence. I know there's lots and lots of debates about A1C. I'm not getting into that debate right here. I just mean at some basic level of evidence, we know it's probably better to be at 8.5 or 9 than at 15. Certainly on the cardiac risk factor side, we also know that we've had good evidence about what to do. Where we're stuck is on the how to do it. Now, you know, the great thing about a national report is it's really great because everyone can say, wow, I thought we were doing better than that, or that looks like we're making progress. And then in the next breath, either say or at least think, thank God that's not us. So for any of this information to be meaningful, it's got to be much, much closer to the ground than a national report, which is perfectly easy to ignore. So every year after we release the annual reports for the country, we also release state reports. So from last year for Michigan, you can see that Michigan did not so well for the proportion of non-institutionalized high-risk adults with diabetes who had an influenza immunization in the last year, right? The all-state average is 47. Michigan's rank here was 41. Similarly, the proportion of adults who needed care right away for an illness, injury, or condition in the last year who got care as soon as they wanted it if they were members of Medicare plans was much, much better in terms of ranking. And, you know, you can make all kinds of pretty reports like that. So that's just a sort of context-setting piece for where does this fit into the broader picture of actually solving almost intractable problems in healthcare, or sometimes they feel like they're intractable. I'm going to shift gears now to talk about training and funding. So clearly, I know many of you, anyone who is in the business of writing grants, will know that the Patient-Centered Outcomes Research Institute just released grant announcements yesterday afternoon. Might have been evening here on the West Coast. But this is a new research institute in the private sector funded with taxpayer dollars, which is an independent, not-for-profit organization created by the Affordable Care Act. The directors of ARC and NIH are on the board, and its mission is to fund research that provides patients, caregivers, and clinicians with evidence-based information to make better informed healthcare decisions, and probably most relevant to the research community, they have a steady stream of funding through 2019. And it doesn't come out of the usual appropriations process. It's from another source. So the announcements posted yesterday affirmed that PCORI will commit about $120 million of primary research funding by the end of 2012. So what kind of work is PCORI interested in? Well, the law specifies that the Board of Governors has to approve a set of national priorities for this work, and they've been put out in draft form for public comment, And these are exactly the same priorities that were finalized and voted on by the board earlier this week. So the first sounds like clinical comparative effectiveness research. The second, very importantly, is all about improving healthcare systems. Now, those of you who are in implementation science and aren't seeing yourselves here, send me an email later, and I will point you to relevant language in these announcements. It's also work in dissemination and communications research and addressing disparities. So those are the 4 announcements that are literally just posted yesterday, and I think that there may be opportunities for implementation science in at least one, but possibly more. The 5th priority, accelerating patient-centered outcomes research and methodology, will be coming later. Precise date right this second, not locked down yet. Now, for those of you who are interested in research methods, thanks to the resources that we have had from the Congress for a while, we are actually having a symposium here at ARC on June 3rd, titled From Assessment from Efficacy to Effectiveness. This will highlight factors that result in differences between results from RCTs and observational studies and so forth. It will provide a forum for discussion of new and emerging research methods in different disciplines and settings. And Shireen Gabriel, who is also the chair of PCORI's methodology committee, will be the keynote speaker.